Okay, I'm going to give you a quick lecture. I don't know if I'll do it all at once or break it up. Half of it now, then let you do the experiment, and half of it at the end. But I need to introduce some molecular techniques that are used in a clinical setting. Tonight you're going to do one called spectrophotometry, and I'll address that in just a moment. First, I want to tell you about ELISAs and Western blots, and I also want to tell you about another technique called serum protein electrophoresis. These are not very difficult techniques, and it's just a small sample of many of the tests that are done in a clinical setting. We've just selected a few of them to tell you about, just to give you enough to wrap your brain around what's happening in a clinical laboratory. First, I want to show you this right up here. This is called a gel electrophoresis apparatus. It's a box that has a gel in it, and you can see that it is connected to a battery pack. That means an electrical current is going to go through the gel. Let me first tell you how we make that gel. It's a lot like making Jell-O. Jell-O, you buy the powder, you add boiling water to it, you pour it into a pan, it solidifies somewhat and turns into this gelatinous, tasty substance. Same thing with making this gel. It's a powder, we pour boiling buffer into it, we pour it into a mold, we can even add a comb, which is seen here on the left side. And when it solidifies, we can pull the comb out, and now we have wells where we could actually add patient samples. We use gel electrophoresis to analyze DNA, RNA, even protein. The only thing that changes is the kind of gel we use. That is not important for you to worry about. So on one of my slides, you're going to see SDS page. It's just another different kind of gel. Don't worry about that. What I do need you to know is that when we apply an electrical current to patient samples, whether it be DNA, RNA, or proteins, they will migrate through the gel as long as they are charged. If they are neutral, they will not move in an electrical field. They have to have a charge, either overall negative or overall positive. The gel box attached to the battery pack has polarity. Just like batteries have a plus and a negative side, when the battery packs are attached to that apparatus box, it too will have a plus and a negative side. The plus side is called the anode, and the negative side is called the cathode. And you should know that opposite charges attract each other. So if your patient samples are negatively charged, they're going to migrate towards the positive side of the box. If they are positively charged, they would go to the negative side. We want to separate patient samples out. If it's for DNA, we can analyze to see if they have a gene mutation. If it's RNA, we can actually separate the different types of transcripts out from each other. Clearly, messenger RNA come in very different lengths and sizes. Proteins, same thing. So separating them out is really useful to us. We can separate them out according to charge, and we can also separate them out according to size. These gels act like a molecular colander. They have little tunnels through them. Anything that's smaller in size can get through them faster. Anything that's larger in size doesn't travel through the gel as well. So what can you tell me about these fragments compared to those? They're smaller, and that's why they're migrating, or we say in our language, they're running faster in the gel. Okay, the important thing to take from that is that those things, DNA, RNA, protein, those molecules, will only migrate through the gel as long as they are charged. Okay, so now we get to the next concept. How do we make them charged? How do we make them overall negative or overall positive? Let's first focus on proteins. Proteins, of course, are made up from amino acids. Amino acids, all of them, have a commonality to them, shown here in the orange box. All amino acids have a central carbon. They all have at least one hydrogen ion attached to it. They all have a carboxyl group, and they all have an amine group. Where they are different from each other is from that R group, also known as the functional group. And there could be anything in that R group. It could be another hydrogen. It could be another carboxyl group. It could be a hydroxyl group, an OH group. It could be another amine group. In fact, each of your 20 amino acids has a different R group shown here in blue. And you can quickly look and see which amino acids have an extra carboxyl group, which ones have an extra amine group, which ones just seem to have a methyl group. And all of those R groups will dictate the chemistry that that amino acid can perform. I need you to know that when a protein is made, the carboxyl group and the amine group of a different amino acid react with each other to form the peptide bond. The carboxyl group, you need to know, is the acid side of the amino acid. Carboxyl groups can dissociate the hydrogen. If the hydrogen leaves, then the carboxyl group becomes negatively charged. Yeah. The carboxyl group becomes negatively charged. How far do you want me to back up?
When a protein is made, a peptide bond is made by a carboxyl group with another.
So two amino acids have to link together. The carboxyl group of one reacts with the amine group of a different amino acid. Between the two, water will be lost. That's called dehydration synthesis. Carboxyl groups can dissociate the hydrogen. When the hydrogen is kicked off, carboxyl groups become negatively charged. That's the definition of an acid, something that dissociates a hydrogen ion. The amine group is the basic side of the amino acid. Nitrogen is quirky. It prefers to have 3 bonds, but it can make a 4th. The amine side is the base side because the definition of a base is something that can bind to hydrogen. Not kick it away, but take it on, sort of adopt it, if you will. When that happens, the amine group side will become positively charged. Now, if we think about this happening on a single amino acid, the carboxyl side becoming negative, the amine side becoming positive, will there be an overall net charge on that amino acid? It's overall neutral. Would it migrate through a gel in an electrical current if it's neutral? It wouldn't. And when an amino acid is neutral like that, it has a fancy word. It's called a Zwitter ion, and that's on a slide coming up. So if you're like, how do I even write that? It's coming up, Zwitter ion. Right now, I just want you to know a Zwitter ion would not move. All right, let's take it a step further. It would not move in an electrical current. We know amino acids link together by peptide bonds to form longer peptides and proteins. So the question now becomes, if the carboxyl group and amine group are occupied in a peptide bond, then how would we get a protein to migrate through a gel then? Well, that's where we start looking at our amino acids' functional groups. Are there some amino acids that have extra carboxyl groups in their functional group? Yes. We could target those and make them negatively charged. We could target amino acids that have an extra amine group and make those positively charged. Depending on which one we want to target, as long as the overall protein is charged, then the protein would migrate through the gel, and we can get it to separate from other proteins. And that is very useful to us, and I will show you why we use it so much in a clinical setting in just a moment. So again, an amino acid that is neutral is called a Zwitter ion. A protein that might have pluses and negatives for their carboxyl groups or amine groups, if a protein is overall neutral in charge, it too would not move in an electrical field. When a protein is neutral, we say it's at its isoelectric point. Little p, capital I. If we want to analyze proteins, we don't want them in their isoelectric point. We want them to have an overall charge. Here's how we can make them charged. I can target the amino acids that have an extra carboxyl group. Remember, that's the acid side, and it's going to kick off a hydrogen. When will hydrogens come off? Remember, acids and bases neutralize each other. So, if I put this protein in a basic buffer like OH, this hydrogen will come off, dissociate, and will bind to the OH to form water. Now that amino acid has an overall negative charge, and this will now move in an electrical field. Okay, so now it's negatively charged. But I could also target amino acids that act as a base, where they adopt a hydrogen. How can I let that happen? And what charge would the protein have? Overall positive. Now, I can make these base amino acids adopt a hydrogen. I want to move this way. So how should I change this on your slide? I want to go that way. I want to lower the pH. Put it in an acidic buffer. Those are our choices. Put the protein in a basic buffer and turn it negative, or put it in an acidic buffer, lower the pH, and make it positive. Either way, now my proteins will have an overall charge and will move in an electrical field. Now I can analyze them. I can separate them from each other. I can even quantify them. And that's very important to us. We're all about measuring everything in someone's blood. Albumin levels, for example. Which of the two methods do you think is our preference to use? Because out of the two choices, there is one that we prefer to use. And that is to put the patient samples in a basic buffer and make them negative. Why? Well, what's your blood pH? 7.40, which is already slightly basic. So we might as well put the patient samples in a basic buffer because they came from basic buffer, basically, and keep them negatively charged. That's our preference. Here is one clinical test that is done very quickly. Doesn't really give us a lot of diagnostic power, and I'll explain why in just a moment, but it is still useful. This is called Serum Protein Electrophoresis, or SPE. A gel is not used. You're seeing a piece of paper that's being used, a special kind of paper called nitrocellulose. We draw the patient's blood, we spin down away the red blood cells, and we basically draw up a sample of their plasma and squirt it on this paper, attach the battery pack, turn it on, and let the proteins separate. In this technique, the proteins are separated according to their charge. Notice if a protein is neutral, it's not going to move. If it is overall positively charged, it's going to travel to the negative pole. And remember, the negative pole is the cathode. If a protein is overall negatively charged, it will move towards the positive pole, which is the anode.
Is that different than normal?
Are you getting hiccuped on the anode and cathode?
Yeah.
Because in physics, you learned that the positive side of a circuit is the cathode, and the negative side is the anode. But in this experiment, the battery pack attached to the box now becomes the negative side is the cathode, and the anode is the positive side. So yes, it's different in different disciplines, and every once in a while I get someone who has taken physics and they're like, I remember cathode with a T meaning positive and anode with the N meaning negative, and now you're reversing this. And I'm like, yeah, I know, I'm sorry. That's how it is when we have the battery pack attached to the box. It is flip-flopped. So great question. I'm glad you asked, but I'm not getting confused in my words. Okay. Next thing. Today you're going to be doing spectrophotometry. And in spectrophotometry, you are going to play with something called the Lambert-Beer law. And the Lambert-Beer law, I'll write it on the board for you when we actually start doing the experiment, states that if you have something that is more concentrated, it will block light traveling through it. Well, what does that mean? What does it look like? And why is that something important to you today? I want you to pretend that our floor is like a dance floor. And dance floors, especially disco places, the lights shine up from the floor, right? They shine upward. And I want you to think of one big giant eye looking down on our classroom. And the light is shining up from the floor. Well, what's going to happen to the amount of light hitting the eyeball at the top of our room? The light hitting the tables. There's not going to be as much light. And what will that eyeball perceive looking down at these tables? They'll see darkness, right? It would be blocking the light in the shape of the table. So it would see large, rectangular, dark patterns. What would happen to the person looking at us if they're looking right here in between the tables? What would they see? A lot of light hitting them, like, right? Here I am I'm getting a lot of light on my face right now. It's very bright. I can take this piece of paper with the proteins that are separated, and I can stain the proteins. The bigger the protein band, the more stain. And if I shine a light through the paper, I'm going to see darkness where there is a larger block of protein. The larger block of protein will take up more dye, less light will get through. In other words, the protein, we don't say blocks the light, we say it absorbs it. It doesn't get through, it's not transmitted. What does that look like? Right here. Here are plasma proteins separated according to their charge. Albumin is first, followed by alpha globulins, beta globulins, and then gamma globulins. Gamma globulins are your typical antibodies. The top picture shows you a normal pattern. Clearly, you should be able to see that albumin is the most abundant protein. It's got a bigger band. It's blocking the light, and that's why your eye sees it as a shadow, a dark band. Now look at the bottom one. What's changed? Clearly the gamma globulins have increased in number. Those are your antibodies. Why might an antibody count go up? Because you're sick, right? Isn't that typically what you think of? The part of the purpose of this little mini lecture is not only to tell you about certain techniques, but it's also to remind you to be humble. And don't go for the drama in your diagnosis of a patient. It's hard to be humble. You want to go for the drama. You want those bragging rights to say, hey, I snagged this in a patient. That was a really good call, wasn't it? But the fact is, when you start to help a physician, some of you might become a physician, when you start your diagnostic nightmare of trying to figure out what's going on in the patient, you're going to order a lot of cheap, quick laboratory work. And this result, if you find this, all it tells you is that your patient has a change in their banding pattern, that their gamma globulins have gone up. It does not tell you why. As a future healthcare provider, the why you should always start with is your usual suspect. What is the usual suspect to cause an increase in antibodies? You all said, if you're sick, like you are fighting an infection, that's the usual suspect. But none of you jump to liver failure. None of you jump to a collagen disorder. And yet those could lead to a shifting, an increase in the gamma globulins too. But that should not be your first thought. It should be, I'm looking for an infection somewhere. Turn to your patient. Do you feel sick? Did you cut yourself somewhere? Is it infected? That's the usual suspect. You can order more tests if you need to help reduce your diagnostic nightmare, to be more specific. But you always start after the low-lying fruit. If you rule that out, then you go to the next level. But you don't start out with the drama. And I'll tell you a story that I told the other classes with an example, a real life story with my husband. He went in for his yearly physical. Of course, they do blood and urine analysis. And his blood work came out with 3 things flagged, meaning abnormal levels. The 3 things were creatinine, unconjugated bilirubin, and increased plasma potassium levels. Now, of those 3, increased potassium levels, as we've discussed, can be very life-threatening. Potassium is supposed to be in which body fluid compartment? Intracellular. Unconjugated bilirubin was elevated in him as well. Unconjugated bilirubin comes from red blood cells that have been ruptured. And the liver is supposed to take that unconjugated bilirubin, turn it into a different form called conjugated, which makes it more water soluble, and then get rid of it from the body. If you do not get rid of bilirubin, it has a yellow hue to it, and you become jaundiced. Okay? Creatinine is a waste product from muscle metabolism. So his creatinine levels were elevated, and creatinine should be eliminated in the urine. So he had elevated creatinine, elevated potassium, elevated unconjugated bilirubin. They repeated the tests, came out the same. They then said, we want you to take a 24-hour urine specimen. They give you a container about the size of those blue drums, and you're expected to capture every drop of urine that you void. You bring that container with you anywhere you go for that 24-hour period. And you store it in the refrigerator when you're not peeing. So imagine going to work and putting that in the employee refrigerator. So he took this 24-hour specimen, and the results came back the same. It was a Wednesday afternoon. I'm on my way to work. I come down the stairs. My husband meets me at the bottom of the stairs, and he says, "You remember all that blood and urine work that I had done?" I was like, "Yeah, yeah. Did you find anything out? What's going on? Something I should know?" He said, "Well, the doctor's office called, and this is what they told him. You need to come in for biopsies. We suspect you have renal and hepatic failure." We went straight for the drama. And I understand why. I do understand why. But that was a big leap. Why did they suspect renal failure? Well, remember, creatinine is eliminated by the kidneys in the urine. If it's not coming out in the urine, then to the doctor, it must have been that the kidneys weren't doing their job. Unconjugated bilirubin is supposed to be converted to conjugated by the liver. If it's not being converted and it's building up in the blood, then the liver must not be doing its job. Potassium is regulated by aldosterone, and this means that the kidneys eliminate more potassium in your urine. If you're not eliminating it, then it's building up in your plasma. So I understand why they led to the renal and hepatic failure. It was not okay in my head that they're saying to him over the phone, "Come in, we're going to do a liver and a renal biopsy." I felt like hitting him over the head, knocking him out, grabbing him by his ankles, and dragging him to the hospital immediately. To hell with the biopsy. If he's having renal shutdown and liver shutdown, he should be in the hospital. So he, of course, being British, he dismisses everything. It's like, "Yeah, keep calm, carry on, it's just a biopsy." And I'm like, "That's a pretty invasive biopsy." So I go to work, I'm crying, of course I am, because I'm thinking, how could this epitome of health be in liver and renal shutdown? It was a Wednesday afternoon, and I remember that because that day I had another physiology section where they met for lab on a Wednesday. This particular section had a high number of students that were ex-military. In particular, they were military medics or corpsmen, so they had a lot of medical training. I come up to unlock the door, crying. Ex-military people don't do well with a crying, hysterical female. And I remember one of them, Kevin McCarthy, not the senator, but Kevin McCarthy, very tall guy, he did this. "You're there." It's okay. And I unlocked the door and I said, "AIS, asses and seats, we gotta talk." This was later on in the semester, after they had learned about acid-base balance, after they had learned everything I'm going to teach you about bilirubin, after they learned about renal, it was towards the end of the semester, and they also had already been taught how to calculate renal function. So I had a copy, I actually took his lab results, and I said, "We're gonna analyze this. We're going to figure out if there can be something else." They know to go after the usual suspects. I said to them, "Let's play the other side of the coin. If it's failure, then yes, these waste products will build up in the blood. But these waste products come from somewhere. What if it's the other side of the coin? What if there's too much production of it? There isn't anything wrong with the liver and kidneys. They're just being overwhelmed with an increased workload. Let's entertain that." So they said, "Okay, game on." They said, "Okay, let's start with potassium. Where's potassium supposed to be? Inside the cells. When can it come out of the cells? When can it ooze out of cells that are damaged? And which cells are probably the culprit?" and when. If you go back and you look at your thermoregulation lecture, under the heat stroke column, there was a very long word, rhabdomyolysis. What is that? Skeletal muscle, in particular, rupturing and leaking out cellular contents. And you have a lot of skeletal muscle. So if that's happening, there's your increase in potassium levels. So the student said, okay, rhabdomyolysis, or damage to skeletal muscles in general, why would your honey have that happening? I said, oh, okay, I got this. My honey has a crazy workout routine to begin with. But when he's going to the doctor for a couple of weeks before going to the doctor, he really increases his workout. It's a lot like the night before you go to get your teeth cleaned, then you floss, but any other time you don't, thinking that your dental hygienist wouldn't even notice. It doesn't work. It's also a lot like when you go to order a Big Mac and a large fry, and because you're on a diet, you get the large Diet Coke because that'll balance it out. So in his head, the harder he works out, the more healthier he will appear to his physician. I said possibly his workouts were too extreme and he's having some potassium leak out of his cells. The students went, oh, like you, okay, could buy it for $1. They said, let's move on to the unconjugated bilirubin. I said, where does it come from? They said damaged, lysed red blood cells. And they pointed out, yet his red blood cell count appears normal. It wasn't flagged. He doesn't have anemia. So what's going on there? And I went, I got it. It occurred to me. A week or two before, he was playing in a soccer game, a very aggressive one. Someone came in for a hard tackle, cleats up, and he had a huge hematoma on his shin. Huge. Lots of bruising. Bruising is from lysed red blood cells, oozing out their contents, and all the colors of a bruise are from the hemoglobin being metabolized. It goes from black to blue to yellow. And there's your bilirubin. And they said, okay, that makes sense. They said, let's move on to the creatinine. Well, that's a byproduct of muscle metabolism. To which I said, weren't you listening when I said he has his crazy workouts? And they went, okay, now what are we going to do? I said, we're going to write a letter to his doctor. But I'm not kidding, this was our lab time. We wrote a letter. And I knew I had to write a letter because there would be none of this, no vote of confidence if I just went home and told my honey, here's why I think you have these 3 things flagged. You see, he doesn't think that I actually know what I'm talking about, even though I've taught physiology for over a decade now. Because he reads the science section in the newspaper, he seems to think he knows more about science than I do. So we wrote it out in a letter, and we told the physician in the letter, you need to ask him to drop his pants and check out the hematoma on his shin. Ask him about his workouts before he comes to see you. And you'll start to make sense that it is not failure, but it's probably overproduction. So I come home with the sealed letter, and I get to my husband and I say, do you want to have your liver and kidneys biopsy? Do you want that large needle to go in you? Do you want to go through that experience, or would you prefer not to? He said, I would prefer not to. I said, then you're going to give this letter to your physician when you go for your biopsy appointment. This is your Hail Mary pass. Run for the end zone and be ready to catch it. You got to give it to him. So he actually listened to me, gave it to his physician, who looked at the hematoma and asked him about his crazy workout. Physician turned to my husband and said, we're going to repeat the tests in 2 weeks. You are not to work out. Do not re-injure yourself. Don't do anything. And my honey obeyed. 2 weeks later, they repeated everything, and everything was normal. So, humble yourself. If things are building up in the blood, yes, I understand that it screams that they're not being eliminated properly, but it could be the opposite side of the coin, where there's too much production. But how many times would a physician say, oh, do you have a hematoma? Tell me about your workouts. Are you crazy about them? Those are not your typical questions that are asked during a normal physical. And although you might be asked to drop your pants, you might not drop them far enough down for your rectal exam to expose your shin, and the doctor might go, how'd that happen? Could be totally not even detected by the doctor. You never know when those things might make a difference. And for my honey, it did. So that's why I'm saying to you, rule out the usual suspects. And if things scream that it's failure, maybe it's the other side of the coin, too much production, and entertain that idea. But certainly don't just go for the drama, because that causes a lot of angst in the patient. To being told, we think you have liver and renal failure, that is dramatic, and it certainly made me upset.
Can I just share like a mini story?
Yes, do you want, I'm videotaping, do you want me to pause
No,
this?
it's
Okay.
I was really stressed from anatomy, like a year ago or so. And like you said, the stress lasted 3 months after the semester ended. I had a headache that I would wake up with, go to sleep with for 3 months.
Mm-hmm.
And I didn't know it was stress. And I was so worried that I decided to go to my urgent care and get it checked out, just in case. Because like I couldn't see and really was rough.
It's debilitating.
Very. So they told me you need to go to the ER right now. I don't know what made them think that, but I did. I went to the emergency room and they made me get a CAT scan. They took the CAT scan and then 3 hours later, they were like, you have something growing in your brain. And they were like, I think it's a tumor, but I'm not really sure. The nurse told me. And I was crying and I felt suicidal for months till I saw a neurologist. The neurologist told me that it was just a mistake on the CAT scan and that they should have had you go take an MRI to actually see. So I thought I had a tumor for 2 months and I was a disaster all over the place because they went to the drama.
Yep. Versus confirming the result. Yeah. It's upsetting. Don't go for the drama. And even if you think something's there, don't, unless you're sure by confirmation with an alternative test. Like with this person, I'm not going to go to that person and say, it could be an infection or your liver could be failing. I'm going to order more tests to figure out which side the diagnosis is swinging to. But I'm going to lean more towards the infection until more tests show me it's not an infection. It's very upsetting to go through that. And like you said, when you need to go see a specialist, many times you're waiting weeks, months sometimes, before you can see them. Meanwhile, that's just rattling around in your brain and causing loss of sleep, lots of anxiety, not just for you, but for family members as well. It's a horrible, horrible feeling. One of my past students called me today, and I picked up, and I said, okay, how are you doing? And she was crying. And I was like, okay, what's going on? And she just got a biopsy result, and she has an adenocarcinoma. She has endometriosis. That's, it's stage 1, and she's very upset, and it's going to be a while before she can actually see the oncologist. And I had to kind of talk her down. I said, no one wants that diagnosis, and I'm sorry this is happening to you. It is stage 1. It is endometrial cancer. Out of all the cancer types to have, if you had to pick one, that's a pretty good one as a female to have. versus breast cancer or cervical cancer. This is a good one to have, and there's a very good prognosis. But with cancer, things typically get worse before they get better. It is no longer the death sentence it used to be 40 years ago. So, I mean, I don't know if I made her feel better, but she definitely got a bad diagnosis, and I was trying to find the silver lining for her. Stage 1, they caught it early. This is not a very aggressive one, and you might not need chemotherapy. You're going to have a hysterectomy. She's in her 50s. It's not like she's going to be having kids. So I said, you don't need it. You know, just take it all out. Just take it all out. It'll be okay. Just cut it out. Now, here is another test called a Western blot. And this was done in Activity 4 of your PhysioX. This is a very specific test. This is not quick and dirty, as we like to say. In this blot, you're running patient samples, protein samples, through a gel. This special technique separates the proteins according to size, not according to charge like we saw with SPE. This is what your gel will look like before you stain it. It's just a smear. That reflects hundreds of thousands of proteins of different sizes. But you're interested in one protein out of the hundreds of thousands that are there. How can we visualize just one protein of a certain molecular weight without identifying all the others? Well, there is another protein that is very good at identifying specific proteins or parts of them. Perhaps you've heard of it. It's called an antibody. Antibodies are very specific to recognize a certain portion of something that's antigenic. It could be a portion of a virus, a portion of a bacterium, a portion of a protein, a portion of something that it recognizes is called an epitope. And if you've taken micro, that is not a new word for you. So for example, you are a whole person. So are you. But yet the two of them have something in common. And if I'm an antibody, the antibodies have two parts. They have a long arm and a short arm. And at the end of the antibody, they have binding sites. For the epitope, they recognize. So I don't need to bind to the whole part. I can bind to the epitope that I recognize. Yep. And it's not hard to create antibodies to recognize a specific protein that you're interested in. For example, let's say I'm studying the blue toenail protein. And I am going to have a technician clip all of your toenails. I won't see who has blue toenails. I'm just going to get all of your toenails from the technician after that technician has ground them up and gotten your protein samples. I have isolated the blue toenail protein, and I have injected it into my favorite bunny rabbit that I'm holding and petting right now. And this is what we used to do. Nowadays, you just call a biotech company and they will inject your protein into any animal you want. But back in my day, I had to inject the protein into my favorite bunny rabbit. And I would inject her over and over the course of 3 weeks to a month. And that is a foreign protein. Bunny rabbits don't have blue toenail protein. So she's now exposed to it, and what will her immune system do? It's going to make antibodies against it. That's the basis of immunizations, isn't it? So after a month and her antibodies against human blue toenail protein have gone up, that's called titer, I can draw her blood, and I can isolate out of all of her antibodies, I can isolate the antibody that recognizes blue toenail protein. Just that one. It's not that hard to do. And now, I can run all of your toenail proteins on my gel. I can add my rabbit anti-human blue toenail antibody, and it will bind to just that protein. Now, the problem is, this is on a molecular level, and my eye has to be able to see this. So how do I amplify the signal? Have you ever been to a concert? How do they amplify the sound? What do they use? Amplifiers, right? They use amplifiers. So what is our amplifier on a molecular level? Another antibody that recognizes the first one. Now you're making layers of antibodies. So now I need a different animal to make an anti-rabbit antibody. Enter my favorite goat. And I can inject my goat with plasma from a bunny. And it will start making anti-rabbit antibodies. To that second antibody, I can attach either a fluorescent probe that will emit a light that I can detect using a black light, or I can attach an enzyme. And if I attach an enzyme, then I can give the substrate to that enzyme, and if it cleaves it, it produces a stain that stains the protein I'm looking at. And that's what you're seeing on that picture. So out of the hundreds of thousands of proteins that came from your toenails, I can figure out who expresses blue toenail protein and how much. It's qualitative, yes, no, and quantitative, how much. It's a very specific tool. I can look at one protein I'm interested in. Clearly, though, this takes a lot of time. It takes a lot of time to make the antibodies, the second antibody. So the first antibody that you add, that's called the primary, meaning first antibody. The second one that you add that recognizes the first is the secondary antibody. Like I said, we can attach a fluorescent probe. Those typically are more expensive than if we attach an enzyme. The one shown here is called HRP. It stands for horseradish peroxidase. A similar technique uses this double antibody approach. A similar technique called ELISA, Enzyme-Linked Immunosorbent Assay. Again, the second antibody is linked to an enzyme. So an ELISA uses fewer hours for the clinician. It's quicker than a Western blot. You still have to have antibodies generated to recognize protein, but it is a faster process than running a gel, a Western gel, and we can do it on a smaller level where we can analyze using a 96 well plate, and we can analyze 94 patient samples at once. You can't make a big enough gel to run 94 patient samples for a Western blot. So we start with an ELISA first. That's what you did in your PhysioX. You started with the ELISA first, and in that activity, you were trying to see if those patients were making antibodies against HIV. The only reason why they would be making those antibodies is if they were exposed and infected with it. You do the quick ELISA before you ruin someone's day, though, to say your ELISA came out positive, you have HIV. You take the patient samples that came out positive with the ELISA and you do the next step to confirm. That's more specific, and that's the Western blot. That is why that one doctor said they should have done the next test to confirm before giving you this bad news. Why, if it's a 96 well plate, why did I say we can process 94 samples? You have to run controls. You have to run a negative control and a positive control. And if those controls do not come out like they should, you cannot analyze a darn thing. Something has failed. You cannot move on. You have to figure out what's going on with your controls and rerun the test. Tests are supposed to be sensitive and specific. Sensitive means that they are good enough where they can detect a positive result. Clearly, though, there's always going to be a threshold. For example, can a woman be pregnant and take a pregnancy test and it comes out negative even though she might really be pregnant? Yes, especially if she takes it the morning after she had sex. She might be pregnant, but why would the test come out negative? It's below the threshold level to detect it, right? She doesn't have enough of that hormone made yet. So sensitivity means it will detect a true positive. But again, there are limitations to any test. Pregnancy tests are always trying to brag about how early you could test for a pregnancy. 5 days, 3 days versus 7 to 10 days for some of the other pregnancy tests. They're trying to make it more and more sensitive to detect even a trace amount of HCG. Specificity means that it tests for something very specific and won't cross-react with something else, meaning it won't give you a false positive. For example, when my coworker, when I was a graduate student, Dr. Zoe, whenever his wife, Jeanouille, got pregnant, for some reason, she would say to him, "I think I'm pregnant," while they were at work. I'm not sure why. During their lunch break, they would go to the grocery store and buy pregnancy tests, plural, bring them back to work. Zoe would go in the bathroom, Jeanouille would go in the women's bathroom. They both would pee on the pregnancy stick, separately. So they bought one for him, they bought one for her. And the reason why Zoe would pee on the pregnancy stick was to show that there wasn't going to be a false positive. He was the control. Being the ultimate scientist, that he was doing the control. I'm not kidding. They had 3 kids. I'm telling you, I witnessed this 3 times. So he was just the consummate professional with respect to doing science. So specificity. He wanted to show also that it wasn't some testosterone hormone that could falsely react with the antibody on the pregnancy test. Again, it should be specific for human chorionic gonadotropin hormone, not cross-react with some other hormone and give a false positive. So that's what we mean by sensitivity and specificity. There are 2 different kinds of ELISAs. There is a direct and an indirect. They have many of the same steps, just in different order. Up here, you're seeing a direct ELISA. Pretend this is not a viral antigen, but instead insert in there human chorionic gonadotropin. Pregnancy tests are direct ELISAs. What is already on the stick is your primary antibody. Its job is to bind to any HCG that happens to come out in the woman's urine. When you pee on that stick, your HCG binds to that first antibody. And the reason why you have to wait a little while is because once the stick is wet, capillary action will bring another antibody to bind to the other side of it, making like an antibody sandwich. You know what capillary action is, right? Yeah?
It's tension. Well, kind of, it's like a surface tension. It pulls polar
Water. Okay, so I'll give you an example. Mac is really good when he was little at capillary action of water going through toilet paper. He would take the very edge of the toilet paper roll, not break it off, just and he'd put it into the toilet bowl, then close the bathroom door. Hours later, I'm like, why is this door closed? And I come in, and the capillary action, the water has gone all the way to the whole entire roll, and it's just dripping toilet bowl water all over my bathroom floor. He thought that was hysterical. And then his father, who is a very cheap person, would put that wet, sogging toilet paper roll out in the sun to dry it out, thinking we could still use this. Let me tell you, it chafes, so don't do it. So while you're waiting for the results, of course, on that pregnancy test, you've got the negative sign. And as the second antibody comes over, it's the second antibody that has that enzyme. And there's something else in the urine that enzyme will cleave, and it forms a stain. So if that second antibody moves over and binds to the HCG, that's when you start to get the stain forming, and you see the plus sign up here. Pretty cool, huh? Mm-hmm. Now, an indirect ELISA, they're showing here a viral antigen, and I'll use that as an example when I talk about this technique, because that's what you did in activity 3 of your PhysioX. You put down HIV viral coat into your 96 well plate. You then added patient samples from 3 different patients. If they had the antibody to HIV because they were infected with it, that acts as your primary antibody. It came from the patient. You then add a second antibody that will only recognize this one. That second antibody, again, has the enzyme. You give the substrate, and it makes a color in the dish. The color tells you not only yes, no, but how much. It is qualitative and quantitative. And how many of you have actually been immunized against chickenpox virus? How many of you are too old? The immunization did not exist, and you actually got infected with chickenpox. Yeah, I'm telling you, it sucks. Getting infected with chickenpox is like having a venereal disease. It is very similar to the herpes virus, in fact. Once you get infected with the chickenpox virus, it's with you for the rest of your life. And it hides out in your nerve endings. Why wouldn't you be immunized against that? I am so glad you got immunized. When I went to graduate school, had to show proof that I was either immunized by the chickenpox immunization, or I had to show proof that I had been exposed to it. And I did not have the immunization, so what did they do? They drew blood. They did an ELISA, an indirect ELISA. The viral antigen that they had on the dish was the chickenpox viral coat. If I was exposed to it, infected with it at one time, I'm making an antibody against it now. They could actually measure how much I made. And that's what we are using or saying, describing when we say the patient has a high titer count or a low titer count. Now, of course, for those of us who had chickenpox, it is still hiding in our nerve endings. And as we age, our titer count starts to drop. And that virus is just waiting for an opportune moment to erupt again along those nerve ending lines, and that's shingles. And it's very, very painful. That is the reason why they give now the booster shots to the elderly so that they can bring up their titer and keep that virus at bay. So that's important that we keep doing that once we get to a certain age. On page, in your lab manual, on page 29 and 30, you have 6 boxes on each page. The first 6 boxes on page 29 go with these 3 pictures here. And on page 30, the next 6 boxes go with these here. We are asking you to redraw these images in your lab manual so that you understand the steps of an ELISA. I'm usually not in the habit of having you just redraw something that's clearly on a PowerPoint, but there are some things missing in this picture. Very important steps are missing in some of these pictures. Who actually did the PhysioX? Okay, what was really annoying about doing the ELISA and the Western blot? When you added the antibody, you had to do something before you moved on to the second antibody. You had to wash, right? And it would not let you move forward unless you did all of your rinsing/washing steps. And you're like, gosh, can't I just click through it? And it made you wait. The reason why they made you wait is because those washing steps are really important. And if you skip them or you don't do them well, you can get a false positive. And in the patients that you were playing with, remember, they're coming to you because they want to be tested for HIV. You don't want to ruin their day because you're lazy and wanted to hurry up and get home. So, step 1, you put down the viral antigen into the plastic dish. Turns out the plastic dishes we use, they suction cup almost the proteins to them. The proteins just stick. You don't have to add glue. You just put the protein in the dish, and the electricity of that plastic kind of sticks it to the protein to it. It's a lot like a sticky booger on your finger that you keep trying to flick off, but it won't. That's how well these plastic dishes stick to protein. The part that is not shown in step 1, that is still very important. Can you see some of the dish didn't get covered with the protein? Aren't antibodies proteins? Could they accidentally stick to the dish? Could that end up giving you a false positive? Yes, it can. So that's an issue. To ensure that none of the dish remains exposed, after you add the antigen, you then add another protein that will block any remaining parts, a protein that a person would not make an antibody to ever, and that's albumin. And where can we get that? Milk. Milk. We just go to the store and we buy milk, and we call that our blocking buffer. Now, I can rinse out that dish. All the surface is either bound to albumin or the virus antigen. Now I can add patient samples. Here's patient A column. This is patient B column. Oh no, patient A is making the antibody to that HIV virus. That means they're infected with it. Otherwise, they wouldn't be making that antibody. But we don't know that yet. We have no visualization of that yet. What did we do from step 2 to step 3? We washed. We washed away any antibodies that weren't specifically binding to that viral antigen. Now, next page, page 30. Here are the next 6 pictures. We add the second antibody. The second antibody has the enzyme linked to it. What step is missing between the picture step 4 and step 5? Washing. So you want to make sure you make a note of that in your notebook. That step seems to be missed. And if you do not wash any unbound secondary antibody before you add the substrate, again, you're going to get a false positive, and you're ruining someone's day. So we wash. Then we give the substrate to the enzyme linked to the second antibody. The letter P in this picture represents a phosphate group. A lot of times the enzyme that we use will cut off phosphate groups from a substrate, and the remaining part, once it's cut away from the phosphate group, precipitates out a solution and gives a color. So now we can identify this patient is infected. We can put it in a spectrophotometer, shine a light through the substance. The more substance there, the more it blocks the light getting through. Hence, the darker it looks to your eye. So it is not just a yes, no, it is quantitative as well. So in your Physio-X, you were analyzing 3 different patients. In the ELISA, you did an indirect ELISA, and in that test, patient A came out negative, patient C came out positive, and patient B was indeterminate. Do we go out to the waiting room to patient B and say, well, it didn't look too good, but I'm not sure yet? No, no drama, not until you're clear as day. So now we do the next test. In a real situation, we probably would have used the indeterminate results and the positive results to go on to the Western. Physio-X, we did the Western blot on all 3 patients. Patient A still came out negative with the Western blot, so that confirms the ELISA. That's good. Patient C came out positive. That's a very conclusive test. Patient B still came out indeterminate. Why? What could be going on where it's indeterminate? The levels aren't high enough. Maybe they're freshly infected. So we're going to ask them to come back in some months, right? And we're going to repeat that test. Unfortunately, they're not going to really want that news that, it's inconclusive, don't know what to tell you, except come back, and in the meantime, practice safe sex, don't share needles, behave as if you are infected, because when you come back and we test you, if you are, you don't want to give this to somebody else. Be on your best behavior. The last test I want to tell you about, and by the way, for the Physio-X, do not memorize the combination of the viral proteins that gave you negative or positive results. That's not the important thing. The important thing is to understand how an ELISA is done, how a Western is done, how they are similar, and how they are dissimilar. How are they similar? They both use a secondary antibody that's enzyme linked. They both are qualitative and quantitative. Do they both use gel electrophoresis? No, they don't. Can both be used to detect a hormone? Sure. Can both be used to detect an antibody? Yes. In fact, that's what you did in the Physio-X. So yes, they can both be used for very similar reasons, but the way they're performed, very different. The last test I want to tell you about is erythrocyte sedimentation rate, or SED rate. It is a technique that uses tubes. The tubes have etched on them little measurements in millimeters. You fill these tubes up with the patient blood up to the top, you put it on a level surface, and you let it just sit there for an hour. At the end of the hour, you come back and you measure how many millimeters of clear plasma can you see? Because the red blood cells, being more dense, they fall to the bottom of the tube. Red blood cells fall to the bottom of the tube at different rates. If they settle very quickly, then you're going to have a lot of plasma. That's a high SED rate. If they don't settle very quickly, you won't have a lot of plasma. That's a low SED rate. Which patient sample has the fastest SED rate? Patient 8. Which patients have some of the slowest SED rates? 2 and 7, and 3 and 1. Those are very slow. SED rates are a lot like SPE. All they tell us is if something has changed out of normal. That's all. But they cannot tell us where the disease is or what it is. All they tell us is the patient's SED rate is not in normal range. Just like the SPE that I showed you, where their gamma globulin band increased, it only showed me that it was different than normal. It didn't tell me what was wrong with the patient. Lots of things can change SED rates. Infections can increase them. Anemias, well, sometimes an anemia will lead to a faster SED rate, except if it's sickle cell anemia, then it'll give a slower SED rate. Thyroid conditions, inflammatory responses. What causes red blood cells to fall down to the bottom of the tube faster than other conditions or other situations? It's something called the rouleau effect. And eventually you will be doing a physio-X where you're actually doing a SED rate analysis. What is the rouleau effect? Have you ever tossed a coin into a fountain? What does it look like as it falls to the bottom of the fountain? It kind of feathers through the water, doesn't it? It doesn't just go plop and sink. Now I want you to think of, you go to the bank and you get a roll of pennies. You know, they package them in the paper sleeves. Take that whole roll of pennies and throw that in the fountain. That's a lot of wishing. What will happen? Will it feather through the water? It's going to go real quick. So that's what red blood cells do when there's a rouleau effect. The red blood cells, think of them as stacks of coins connected by proteins. It's not a clot. It's not a clot. The red blood cells connect to each other because of inflammatory proteins connecting them, like Legos. And then they become more dense and they fall to the bottom of your tube faster. Why would we use SED rates? When are they useful to us is probably the better question. We use SED rates to monitor if a patient is improving, if they've had an inflammation, if they've had an inflammatory response, I should say, like rheumatoid arthritis. That's an autoimmune disorder, leads to profound inflammation. That person would have a high SED rate. But if we put them on cortisol, you learned about cortisol tonight, it would suppress their immune system. That means it will help their disease. And their SED rate should decrease. And when it changes from being too fast to decreasing, we know that their inflammatory response is being curtailed by the cortisol, that they're improving. It's not necessarily curing them, but it's helping them. Is that good? All right, I'm going to stop my video.